Thank you. Good morning. This is my first visit to Uruguay. Hope it won't be my last. The hospitality of the organizers, the quality of the meeting, and the taste of the wine were all spectacular, and I hope to come back. The guidelines, as we have constructed them, are designed to help the clinician make decisions so that Class A and B are in green because they mean that the clinician does not have to act. So Class A is somebody at risk for valve disease, maybe a patient who is born with a bicuspid aortic valve. Class B, progressive disease, means that the disease has not yet become severe and is not yet causing problems, but there is evidence of valve disease, and that requires just close follow-up by the clinician. Class C2, asymptomatic decompensated valve disease, or Class D, symptomatic severe disease, all mean that some action has to be taken. That's why they're in red. So if the patient already has evidence of left ventricular dysfunction, even though he says he's asymptomatic, or if they have become symptomatic and the symptoms are due to valve disease, you must act. You must either repair or replace the valve, unless it's a lawyer and you want to see them die a slow, painful death. Otherwise, you must act, leaving just Class C1, the most difficult group of patients with severe asymptomatic valve disease, give us the hardest problem to solve. Now, I've been writing the guidelines for 20 years, and it's something I'm very proud of, but the guidelines are not commandments. And if you practice within the guidelines 100% of the time, you're not being a good doctor. No guideline can represent every patient that comes into your office. And no guideline can override clinical judgment, the experience that we develop over years of how to deal with our patients. Proof of that is we define severe aortic stenosis as 1/440 and 0.6. That is a valve area of 1 square centimeter or less, a jet velocity of 4 meters per second or more, a mean gradient of 40 millimeters of mercury, or an index valve area of 0.6. For the velocity, there is some good data. Catherine Otto's data that says that if the patient with a jet velocity of more than 4 meters per second comes into your office, they only have about 2 years to go before they're going to develop symptoms and need an operation. But the gradient, we say, is 40. In 1998, I was on the committee then, we said it was 50. Now, where did those 10 millimeters of mercury come from? No new data, just different members of the committee. Makes you worry, doesn't it? And then if you look at our data themselves, they are internally inconsistent in about 31% of patients. So patients that fall down and to the left or up and to the right don't fit both definitions. So these patients have a valve area in the severe range, but a gradient in the moderate range. What do? You have to use your clinical judgment to decide whether that patient truly has severe aortic stenosis or not. So here's a patient, a 71-year-old man who says he's asymptomatic, appears to be healthy. He's got a jet velocity of 4.3, a mean gradient of 60, a valve area of 0.8, preserved ejection fraction. This is somebody in Class C1, severe, apparently asymptomatic aortic stenosis. What shall we do with him? We said it's Class 1. It's pretty easy. If the patient has symptomatic aortic stenosis, everyone knows that requires surgery. Asymptomatic with LV dysfunction, very rare, I think, but you would also operate on that patient. Or if the patient had severe disease and was going to undergo, say, coronary revascularization, you would certainly replace the valve then. But our patient is asymptomatic. And Pat Pellica has probably the largest group of these patients, 622 patients with jet velocities of 4.5. So we're pretty sure that these patients were had severe asymptomatic AS. And the results, looking at those patients over time, operated when they developed symptoms, the patients had a slightly less good outcome, but not statistically different than an age-matched population. Raphael Rosenheck in Vienna had a smaller group of patients, asymptomatic severe AS, that he followed for 6 years. There was only one sudden death in that group of patients. And if you look overall, the risk of sudden cardiac death in the asymptomatic patient with aortic stenosis is about 0.5% to 1% per year. But not all patients have the same risk. There are some aortic stenosis patients who have higher than average risk, even though they say they're asymptomatic. And they form the 2A recommendations. Patients with very high jet velocities and very tight valves, or patients with a positive exercise test, or patients that even if they say they are asymptomatic, we should consider aortic valve replacement. The data that support that come in part by Raphael. If your patient has a jet of more than 5, they've only got about a year to go before they get symptomatic. And the argument is, what are you waiting for? Why not just go ahead? I mean, surgery today is so safe. Less than 1% risk in the operating room of such a patient. Why not go ahead and fix that valve now? If the patient says he's asymptomatic, he's going to exercise no matter what. Why not examine that patient? Why not view an episode of exercise in front of you? Patients that have a good exercise study, Amato's group, have a pretty good short-term outcome. But in the exercise lab, on the treadmill, about half of patients that say they're asymptomatic suddenly become symptomatic. They've been denying those symptoms, and now faced with having to perform on the treadmill, you see that either they have a very short time on the treadmill, or their blood pressure fails to rise, or they develop ventricular arrhythmias. Those are patients we should seriously consider replacing their aortic valve now and not waiting for overt symptoms to develop. The therapy of this disease is changing as we speak. This original Sapien 1 valve isn't even available anymore. That picture was taken in 2011, and already that valve is out of practice. That's how rapidly this is evolving. Everyone knows these data from partners that demonstrates that for inoperable patients, TAVR, transcatheter aortic valve replacement, is better than nothing. No surprise there. Then came the core valve pivotal trial, which suggested that in fact, in high-risk surgical patients, the transcatheter valve replacement might even be safer. In the intermediate group, the Partners 2 that just came out, from the femoral access, which was a pre-specified endpoint, patients actually did better with TAVR than they did with surgical aortic valve replacement. Just to show you how rapidly this is, in the 17 update of the guidelines, we said that TAVR was a class 1 indication for inoperable patients in high risk, and it was a 2A for intermediate risk. Technically, that only lasted for 48 hours. The guideline came out on a Wednesday, and on Friday morning, the core valve people presented Evolute R data indicating that also in intermediate risk patients, there was non-inferiority of TAVR with surgery So now you had two large randomized trials saying the same thing, which would technically make that a class 1 indication for TAVR in intermediate risk patients. So we didn't change the guideline. There was no way to do that. But technically that guideline only lasted for 48 hours. That's how rapidly this is evolving. I think one thing that's in that trial, actually strokes were less in TAVR than they were for surgical replacement. And I think it's very interesting to try to understand why patients undergoing these procedures are having strokes. Virtually everybody, 100% of patients that have a TAVR, have new MRI findings post-TAVR, but only a small percentage of them actually have clinical strokes. Could it be that the debris that is loosened at surgery is different than the debris that a TAVR upsets? I have no idea. But it is, I don't think we fully understand exactly why patients either with surgery or with TAVR are having strokes, or why they're not having strokes. And I think that's an area that we've got to look into. Switching gears to this patient, a 72-year-old man who gets out of breath walking 50 feet to get his newspaper in the morning, 3-pillar orthopnea. All the physical exam findings of heart failure. And in the echo lab, he's got a lousy ejection fraction, a low jet velocity, and a low gradient. This patient with low flow, low ejection fraction, low gradient aortic stenosis. And what to do with him. First of all, where do these people come from? I think we're seeing more and more of them, and these data suggested that maybe they're born that way. So that if you look on the left, here's a group of patients that start off with a gradient of 30. Over time, the gradient virtually doubles, and the valve area has gone from 1.4 to 0.8, but there's really no change in ejection fraction. That patient or that group of patients tolerated their pressure overload quite well. But look on your far right. Here's a patient with what we would call moderate aortic stenosis, a gradient of only 20, and already that ventricle isn't normal, an ejection fraction of 53%. And then you add 7 millimeters of gradient up to 27, and the ventricle falls apart. The ejection fraction has gone from 53 to 40. And I think there are patients who are inherently born with an inability to tolerate a pressure overload. I mean, after all, why should we be all the same? And some patients just don't tolerate a pressure load well, and they're the ones that show up in our office with a low ejection fraction and a low gradient. And now the question is, what do you do with them? They don't do well at surgery. Data from the Mayo Clinic indicate 28% operative mortality in that group of patients. But some patients get better after surgery, and the question is, how do you know? First of all, there's a difference between low gradient and very low gradient. So patients that can't develop a gradient of 20 millimeters of mercury, first of all, it doesn't give the surgeon or the TAVR operator much chance to make an improvement. If the gradient's 20 now and they have 5 millimeters after the valve is replaced, you've done all that to get rid of 15 millimeters of mercury pressure gradient. It's not very encouraging. And if the reason that the gradient is low is because of extensive coronary disease and myocardial infarction, that group of patients just doesn't do well. Inotropic reserve is helpful, so that patients, when administered dobutamine in the cath lab or the echo lab, that have a 20% more or more increase in stroke volume, have a pretty good outcome. That is group 1, with an operative risk of about 10% and a pretty good long-term outcome. They do much better than this group treated medically. There is no medical therapy for aortic stenosis. They also do better than group 2, those patients who fail to have inotropic reserve. And when you think about surgery, the most important mechanism for separating a patient from cardiopulmonary bypass is the use of postoperative inotropes. If a patient can't respond to inotropes, then our ability to wean them from extracorporeal circulation and to support them in the postoperative period is reduced. And so we make, those are a 2A, patients with low flow, low gradient who have inotropic reserve do pretty well and do better than not. However, in those patients that were followed up, so group 2 are the patients that lived, 30% died, but the patients who lived through surgery had every bit as good an improvement in ejection fraction postoperatively that those that failed to have inotropic reserve. So inotropic reserve is important. It's an important risk stratifier, but it still doesn't solve all of the issues about whom to operate on or TAVR. So what about TAVR? Well, first of all, if you look at the outcome, and this was the subset from Partners 1, if you look at, these are 2-year death rates, and these are low flow patients treated either with TAVR or surgery versus high flow patients, and they clearly do worse. So it's not very, so the low flow patients are still at high risk, but if you compare the low flow patients, low gradient, low ejection fraction treated with so-called medical therapy versus TAVR, they do much better with TAVR, but at 2 years, there's still a 50% mortality. So they do better with TAVR than nothing, but they don't do that well. These ventricles are really, really sick, and some get better, some don't. And I think we've got to go past ejection fraction and gradient. We have to understand more about the biology of those ventricles in order to understand who's going to get better and who's not. It's not a simple problem. And then finally, this kind of patient, this 80-year-old woman who's symptomatic from her aortic stenosis and typical physical findings of severe disease, very thick left ventricle, a preserved ejection fraction, but a low gradient. She's ejecting a normal percentage of a small volume. The ventricle is so hypertrophied that the end diastolic volume is small. There's no room for the blood. And even though she's ejecting 60%, but she's ejecting 60% of a 70 cc end diastolic volume, gives you a stroke of 42, and that's what makes the gradient. So the reduced stroke volume, not because of poor systolic function, but because of the inability of the ventricle to fill in diastole, lowers the gradient. But still, this patient has severe symptomatic aortic stenosis. What's the solution for her? First of all, you have to make sure that the patient has it. Remember, this patient only fulfills one of the diagnostic indicators of severe disease, just the valve area. Her gradient doesn't make it. The jet velocity don't make it. So it all has to fit. The physical examination. Is there severe calcium in that valve? On echo, does the valve move, or is it stationary along with the valve area? When you look at this group of patients, and so here are your low flow, here are the low flow patients with a preserved ejection fraction. Their global longitudinal strain is reduced. That ventricle is sick, even though the ejection fraction is preserved. It's a real disease. And in terms of their outcome, if you look at the low flow patients, low flow versus low gradient patients versus high gradient, they do worse. Just because their ejection fraction is preserved, the ventricle is still excessively hypertrophied and is not a normal ventricle. So they do worse than patients with high flow. But if you look at the bottom panel, they still do better with surgery than they do with nothing at all. And I suspect that they do better with TAVR than with nothing at all. And if you look overall, the folks with the best outcome are those patients with high gradients treated surgically. And so patients with high gradients treated surgically do the best. Patients with anything treated so-called conservatively, means nothing, did the worst. And this group of patients with paradoxic low flow, that is to say, their ejection fractions are preserved, do better with surgery than nothing. They just don't do as well as patients with normal flow. So, first of all, the definition of severe aortic stenosis is easy in somebody that has a gradient of 80 millimeters of mercury, but frequently they don't. And frequently the definitions in the guidelines are discordant. And in that group of patients, it requires our skill as physicians and our experience with the disease to help us decide whether the aortic stenosis is truly severe or not. It's not written in stone. TAVR is evolving as we speak, and in my view, it makes the heart team more important, not less important. In order for us to really decide and help a patient decide which of these therapies is the best for him or her, we need all of our minds. We need our surgical colleagues, we need cardiology, we need the structural cardiologist, the imager. We need everybody to come together and help make a decision about what is the best therapy, and it's going to become more difficult as TAVR moves to lower and lower risk groups of patients. And finally, this low flow group is continuing to be a challenge. First of all, we have to understand how the patients got that way, and then understand the biology of that ventricle more than just its movement, to help us know whether or not that patient is going to get better after we replace the aortic valve, whether by TAVR or SAVR. Thank you very much for your attention.